Hi there. This is Dr. Monica Agarwal. I'm here to bring you another podcast episode today of Seeking Voices, exploring the science of health and healing. This is a podcast that focuses on the real science of nutrition and lifestyle to heal the body. We're interested in talking to speakers about sleep, nutrition, lifestyle, stress, you name it. We want to bring you the real science. It's so nice to see you. Today, I have a wonderful speaker. I have Dr. Michael Breus. Dr. Breus is a clinical psychologist and a diplomat of the American Board of Sleep Medicine and a fellow of the American Academy of Sleep Medicine. He's only one of 168 psychologists in the world who have passed the Sleep Medical Specialty Board without going to medical school. He was recently named top sleep specialist in California by Reader's Digest and one of the 10 most influential people in sleep. He's been on the clinical advisory for the Dr. Oz show and been on the show about 40 times. What I like about Dr. Breus is so many of his interesting books. He's the author of The Power of When, which was a number one bestseller on Amazon for time management and happiness. It was a biohacking guide proving that there is a perfect time to do everything based on your genetic biological chronotype. He also has a second book, The Sleep Doctor's Diet Plan, Lose Weight Through Better Sleep. And his newest book, Sleep, Drink, Breathe. I'm really excited about this episode because I have so many questions about sleep, and I wonder about if you do too. I want to know, when is the right time to take a nap? Is napping okay? What is the right amount of time? What is the right amount of sleep to sort of help with your memory? When I look at these sleep stages on my Apple Watch, I'm always trying to figure out which is the right amount of time and how to maximize time in certain sleep stages. If these are some of the questions that you have, you're going to love this episode. Stay tuned. Thank you so much, Dr. Breus, for being coming on my show. I really appreciate it. I think the listeners are going to have a lot to hear and learn from you. I'm looking forward to hearing from you, but I thought that maybe you could just start by telling us a little bit about who you are from your perspective. We've already told the audience so many great things about what you've done.
Thanks for number one, thanks for having me on the show. I'm excited to be here, and I'm excited to talk to all of your listeners/viewers that are out there, because there's a lot of interesting information when it comes to sleep. So here's the thing. I didn't start out as wanting to be a sleep doctor. I wanted to be a sports psychologist of all things. I got my PhD in clinical psychology, and I was going to do a residency similar to a medical residency. It's a 1 year, almost like a fellowship, probably more like a fellowship than a residency. And the place I wanted to get into, I couldn't get into. It was reserved for the Harvards and the Princetons and the Yales of the world. I went to the University of Georgia, top 20 program, but it wasn't Harvard. But there was a side track where you could study sleep, and they would pay for your entire fellowship. And then you could, make it into the program that way. So I had worked my way through the electrophysiology department. So I'm the nerdy guy that likes to take apart EKG machines and put them back together, and EEG machines and all that nonsense.
That's cool.
And sleep uses the same kind of machines. So I figured I'll sell myself as a sleep guy, and then I'll just transfer once I get there into the sports psychology program. Well, lo and behold, I got there, and the administrator said, "We had a feeling you were going to try to transfer, Michael. So here's the deal. You got to be there for 6 months, but then afterwards you can go to any part of the program that you want. But you got to be in the sleep lab because they're the ones that are paying the bill for you for the year." I was like, awesome. How tough could this be? It's sleep, right? What could be so difficult? By day number 3, I fell completely in love with clinical sleep medicine, and I knew I was never going to change. I help people this fast sometimes. It's unbelievable. As a traditional clinical psychologist, it could take weeks, months, even years to see any level of treatment gains in depression, let's say, or anxiety, or any of those. But if I can identify obstructive sleep apnea in somebody, narcolepsy in somebody, insomnia, all of those are highly treatable, and we have great results. So I really basically fell in love with the science of it and the medicine of it, and I kind of never looked back after that.
I love that. It's one of those classic, what we tell our kids: when one door closes, another door opens. I will tell you, I was a religious studies major in college. And then my
See?
father, and my father said, and halfway through, he said, it's all well and good that you like to study religion, but you need to get a job. And so if you don't pick a science career or some sort of career other than religion, I'm not paying.
There you go.
So
The hammer came down.
the hammer came down. So classic. So anyway, so nice to hear that story. So tell us, you are known for so many things, and I have so many questions for you about sleep, but I want you to tell us about what you really made your name in, which is these chronotypes. Talk to us about those.
Yeah. So it was interesting. So it all started with a patient. Doesn't everything always start with the patient? I had a patient and I failed. I mean, when I say I failed, I failed. I mean, we tried cognitive behavioral therapy, we tried medication. This is an insomnia patient, by the way.
Okay.
Tried CBT, tried pharmaceuticals, tried supplementation. I couldn't get anywhere. She couldn't fall asleep before 2 o'clock in the morning, and she was coming late to work. It was a mess. And so I brought her back in, because when I fail, I bring people back in and I just figure I must have missed something. Let's do another clinical interview. Let's review all your tests. And she said something in the middle of the interview that kind of sparked my interest. And she said, I was living on the East Coast at the time, practicing in just outside Atlanta, Georgia. And she said, Dr. Breus, if I just lived in California, everything would be perfect. I was like, well, California's a great place, but what are you talking about? And she was like, the time. She was like, if I could just be 3 hours behind everybody else, she's like, it would be no problem for me, because I can't fall asleep before 2, and I'm sleeping until 9:30, 10 o'clock. And I said, well, why don't you talk to your boss and let's see if we can get your schedule changed? Like, this seems like a pretty straightforward fix. And she said, I'm going to be honest with you. I'm pretty sure I'm getting fired. I'm on probation. I fall asleep at meetings. My work product hasn't been really great. I'm not sure they're going to give me any leeway here. And I said, look, would you be okay with me talking to him? Sure. So I got her permission, give her boss a call. He said, look, I'm firing her at the end of the week. And I was like, great, no pressure, right? And so I said, all I want her to do is I want her to come in at 10:30, and I want her to leave at like 7:30. Is the office still open then? Will that work out? And he was like, yeah, no problem. He was like, but I'm telling you something, doctor, this isn't going to work. Okay, just give me a few days. 5 days later, I call back up. It's Friday. He picks up the phone. First words out of his mouth, I've got 3 more employees I want you to talk to.
Ha!
Right? So what had happened was she was an extreme night owl, right? And so when we talk about chronotypes, a lot of people may not have heard the term chronotype before, but many people have heard of this theory or been called either an early bird or a night owl. Those turn out to be chronotypes. Here's where it gets interesting, is they're genetic. It's not like you get to choose. So, I love the person who says, I'm an early bird, and they're forcing themselves to wake up every day at 5 o'clock in the morning. No, you're not an early bird. People who naturally wake up at that time are early birds, right? And so what I decided to do was take a look around and try to understand more about this. When I started to develop and go into it and start creating online diagnostics and things like that, I found a 4th chronotype. That's probably the thing that I'm most known for, is the 4th chronotype. So early birds, we call them lions, because who wouldn't want to be the king or queen of the jungle? I mean, let's be honest, right? And these are kind of my early morning optimists. These are oftentimes my operators, so the COO of a company. They like to make a list and go from step 1 to step 2 to step 3 every day. They're very organized, very regimented in their thinking, but dinner and a movie is out for a lion, because they've been up since 4:30, 5 o'clock in the morning. Like, there's no universe they're going to be social. So again, pros and cons. People in the middle, we used to call them hummingbirds. I call them bears. By the way, bears make up 50% of the entire population. So half of the population, the 9 to 5 work schedule is perfect. They start getting sleepy around 7:30, 8 o'clock. They're in bed by 9:30, 10. They wake up around 7. They get to work. Works perfectly for them, right? Then we've got the night owls. I call them wolves. By the way, I chose animals that actually have the same chronotypes as what I'm talking about. So lions, actually, their first kill is before dawn. Wolves are very nocturnal creatures. Bears kind of wander around during the daytime. Now, let's be honest. I probably haven't told you a whole lot that you didn't already know. I mean, early birds, night owls, there's got to be people in the middle. Michael, this has been around since the dawn of time, okay? Tell us something new here. Well, what I discovered was that there was an irregular genetic propensity on the PER3 area of the human genome that showed us an irregular sleep schedule. So it was kind of fascinating. It makes up about somewhere between 8 and 10% of the population. Now, to be clear, if you know your circadian biology, there's almost 70 different areas within the human genome that can have effects. I'm mentioning one. To be clear, when I developed the whole idea behind dolphins, it's multiple areas, but I just didn't feel like getting into the weeds with everybody. So the one, if you want to look it up, the PER3 is probably the most demonstrative of what we're talking about here. But it's kind of cool. And so once people knew which category they fell into, we were able to give them pretty strict guidelines for when to go to bed and when to wake up. And that turned out to be, it's kind of like, your mom tells you when to go to bed and when to wake up, when you're itty bitty. And if you listen, you actually do pretty well. And so what we did was we started to give people more and more information. Then we figured out that this unlocks an entire new set of things that you can do. As an example, if you know that you're an early bird, or what I call a lion, we can very easily predict times of the day where you have higher levels of cortisol, and then maybe you do exercise during that period of time, or maybe, so you could follow your hormonal balance based on your chronotype. So I wrote a book called The Power of When, W-H-E-N, in terms of when to do something in your 24-hour cycle. And we discovered, believe it or not, the best time of day to have sex, eat a cheeseburger, ask your boss for a raise, go to bed, take a nap, you name it. And all real data. There's over 220 studies in the book, not my studies, to be clear. We gathered data from around the world because there's circadian researchers all over the place. So it turned out that this was kind of a cool unlock for a lot of people who were just saying, gosh, I don't know a lot about my sleep, and I wish I could get better quality sleep. This gave people some guide rails to say, oh, here's a category of circadian rhythmicity, right? Early bird, night owl, lion, wolf, that I can now engender, become part of, and now I've got some guidelines of what to follow, versus these generalized sleep hygiene recommendations, which, let's be fair, you've been giving those to your patients for years and years and years. They never change. It's go to bed in a cool, dark room, turn off all the lights, turn off all the noise. That's great, but that's not going to fix insomnia.
So it's very interesting. So, when I think about circadian rhythms, I think about adenosine, and I think about melatonin, and I think about cortisol. So are you saying that?
So let's talk about those for half a second. So cortisol and melatonin have very finite circadian pathways, and we know quite a bit about them. And those two hormones in particular, I would argue, probably represent 85% of circadian rhythmicity, right? There's a few other things that can come into play and things like that.
And before you go on, can you explain what cortisol and melatonin are to our audience?
Absolutely. So when we think about cortisol, this is a hormone that your body produces in the instance of what we call fight or flight, right? And so this is the get up and go hormone. This is the when you need energy unbelievably quickly, like to run away from a tiger. That's what cortisol is good for. Now, to be fair, not everybody's running away from tigers. And so the good news is cortisol is one of the two hormones that helps wake us up in the morning. When cortisol and adrenaline kick into gear, that actually pulls you out of a state of unconsciousness. Now, melatonin kind of does almost the opposite, right? And so melatonin is known as the sleep hormone, only comes out in darkness, and melatonin really helps propagate what's called the parasympathetic nervous system, right? So cortisol kind of jumps you awake, and that kicks into gear the sympathetic nervous system. And then melatonin is the hormone that comes on board, usually, again, during darkness. So we have to wait until the sun goes down. We have to wait until your body temperature starts to reduce. And then those are enough signals to your brain to pop out some melatonin, which helps tell your body it's bedtime. So the way I like to think of it is there's two separate systems in the brain. One is sleep drive, the other is sleep rhythm. Sleep rhythm is controlled by cortisol and melatonin, and sleep drive is where adenosine really plays the largest role. So what is adenosine? When a cell eats a piece of glucose, something comes out the back end. One of those things is adenosine. Adenosine works its way through the system, gets to a very specific area in your brain, and then as it accumulates, you get sleepier and sleepier and sleepier. So when we think about the two systems, I would say adenosine is sleep drive, and melatonin versus cortisol is sleep rhythm.
So, when I think about these sleep patterns and circadian rhythms, I don't think about it in terms of different chronotypes. I think about it in terms of age related, right? Like when we're adolescents, we have a different circadian rhythm, our melatonin levels rise later. And I don't necessarily think of them in terms of an adult life. Like I thought, and this is probably my lack of understanding, is that there was one general rhythm for adults. And you say that that's true for the bears, or 55% of people are bears.
So here's what I'll tell you is we've kind of developed this concept that we call chrono-longevity. And here's what it means is everybody goes through every one of the chronotypes, right? And it's based on age. So you correctly already identified this. So what I'd like to do is take those ages that you just mentioned, and I'll show you how the chronotypes actually fit in there quite nicely. So when you're looking at babies, itty bitty, teeny tiny, squishy ones, right? They're lions. They go to bed really early and they wake up really early, right? Once you get them into sort of toddler universe, middle school, they become bears. They go to bed around 7. They wake up around 7. Then adolescence hits. What do we know about teenagers? They want to stay up late and they want to sleep late. So now they've turned into wolves, right? So you can see this progression through the ages. What's interesting is it seems to really, the true chronotype seems to express itself somewhere in the 20s, like early 20s, and then it appears to set. Then it stays that way for about 40 years, and then it starts to reverse. I'll give you an example of the reversion, which is if you ever ask your mom or your dad if they're still around and said, hey, you want to go to dinner? What time do they say they want to go to dinner? 5:30, right? Because now their chronotype is actually going backwards, right? So in the beginning of life, we see chronotypes moving forward from the lion to the bear to the wolf, right? Then you set up, then whatever your chronotype is, we have a tendency to see it go backwards. So bears become lions, wolves become bears. Now, lions do have a tendency to stay early birds. I will tell you that, which is, again, characteristic of things that go on during aging. Now, one person asked me, well, like, Michael, I got to understand this. Like, why do old people seem to go backwards in their chronotypical environment? And if you look, we think it has to do with potentially one big factor, which is light exposure. So what ends up happening is people, as you know, as people get older, their corneas begin to yellow and the lens begins to yellow, which means not as much light gets in that gets all the way back to the glands that produce all this stuff, like the pituitary gland and the suprachiasmatic nucleus and all that kind of good fun stuff. So we think that one of the things that's going on and the reason we got this idea was when so my best friend is a neuro-ophthalmologic surgeon. And he was telling me that when he was doing a cataract transplant, I think, or something like that, he said, everybody's sleep gets better. I'm like, what are you talking about? Post-surgery, people's sleep gets, like, you never hear somebody telling that kind of story. And he said, yeah, he said, my patients now have to wear sunglasses because we've got the cataracts out and they can see better and there's more glare. So they're actually getting more light in and they're reporting going to bed later and feeling better and sleeping better. And so I think, like, my hypothesis is that might be one of the things that's potentially going on.
So that's very interesting. So as you age, it's not just that people change their sleep pattern. A lot of elderly people, while we know they shouldn't, often sleep a whole lot less. So how do we explain that?
So historically, when we look at the data, what we discover is they actually don't sleep less, but they sleep more sporadically throughout a 24-hour period. So what ends up happening is you're watching a game show or a ball game and, your eyes fall. You take what we call an unscheduled nap. That seems to happen quite a bit for people who don't have a lot of activity that is going on in their lives, or they're in the retirement phase, or they're just not as mobile as they once were. So they do have a tendency to be more sedentary. And then when you get more sedentary, it's easier to just kind of nod off and then kind of come back to it. So if you if you look at the data and you track people who are like 70, 80, 90 with a wrist tracker or something along those lines, like an actigraph, what you discover is they're still getting roughly the same amount of sleep that they personally got earlier in life, but it's kind of divvied out over time in terms of these napping episodes. So one of the first things that I do is I try to consolidate their sleep by saying, hey, let's cut out napping if at all possible. And let's see if your sleep quality begins to improve, because invariably it usually does. Also, if I'm being fair with my elderly patients, and so I'm 57, so I'm banging on the door myself, is a lot of them have habits that they don't think about that turn out to be anti-sleep, right? The biggest one is caffeine consumption. So many of my 70 and 80-year-olds are like, what are you talking about, Michael? I've been drinking coffee since I was 14 years old. It doesn't have any effect on me, blah, blah, blah. You know, and you get into these interesting discussions.
Sure.
And to be fair, they don't feel the effects of caffeine because, number one, they've had so much of it in their system, they've adapted to it. But what they don't understand is just because you don't feel it doesn't mean it's not having an effect. And so we look at some of those habits, like having a scheduled bedtime. And by the way, a lot of my older patients, they get bored by about 6:30, 7 o'clock. And so they're like, I don't have anything else to do, Michael. I'm going to bed. Versus, hey, I'm going to stay up until 9:30, 10 o'clock when the body is naturally getting tired, right? And then be able to fall asleep. So when we start to look at elderly and they say, oh, I'm not sleeping as much, or the quality of my sleep isn't good, those are some of the factors that I zoom in on immediately.
That's helpful. I think, though, that we also there's a role of frequent urination, undiagnosed sleep apnea.
Absolutely. So let's tackle those two as well. So first of all, fluid and fluids, when you're taking them, is a massive issue as you get older. Trust me, I'm dealing with this myself. And so when you start to learn about this, it becomes disruptive to your sleep. And so for a lot of people, they're waking up multiple times to go to the restroom. So first thing we start to look at there is the idea set of, hey, maybe you're drinking fluids too late into the evening. So a lot of people will say, but Michael, I need to be hydrated. Yeah, I get it. I wrote a book on hydration, so I understand how hydration works. But what I'm here to tell you is if you can get your water before about 3:30, 4 o'clock in the afternoon, like if you can get 80 ounces in you before 4 o'clock in the afternoon, and then you're very light in your water and your fluid intake after that, it is absolutely going to serve you well. I used to give the advice of saying 3 hours before bed, stop alcohol, 2 hours before bed, stop food, and 1 hour before bed, stop fluids. And I've decided to revise that. And I really have all three of them stop 3 hours before, because we've really started to discover that if you eat later in the evening, it raises your heart rate. And that elevated heart rate makes it very difficult to get, not only to get into sleep, but more specifically to get into the deeper stages of sleep, which as we age, we really want to get into stages 3 and 4. So hydration and fluid limitation, I think, is something that a lot of people should look at. I've had patients where they just do a water diary for me for a week, where they just write down, when they're drinking, how much they're drinking. And we say, oh, hey, let's just push that up a little bit in terms of time and see if we can kind of get you away from that. Now, of course, there are people out there, men in particular, who have enlarged prostates. And so if you're going to the bathroom multiple times, that is a reason for you to go to your doctor and say, hey, I need to get my prostate checked. I'm going to the bathroom multiple times. Also, you correctly bring up sleep apnea, right? And so one of the big things that we know with undiagnosed sleep apnea is nocturia, right? So people getting up and peeing most of the night. And that becomes, again, problematic because it's so disruptive to sleep. Also, if I'm being honest, people get pissed. Like, I mean, not literally, I guess literally, but people get upset, I guess I shouldn't use that word. People get upset because they're like, oh my gosh, I can't believe I have to go to the bathroom a third time. And what that does is that brings up anxiety and that brings up heart rate. And it really makes it more difficult to fall asleep. And so I'm usually talking with people right after I meet them and say, hey, do you know what the signs and symptoms of undiagnosed sleep apnea are? So snoring, your bed partner may notice that you stop breathing in your sleep. You might wake up gasping or choking. Even one time is enough for us to know, because if it happened once, it's probably happening a lot. Waking up the next day feeling super groggy, maybe having a headache in the morning, or maybe finding that your mood is up and down when you used to be kind of a steady stream sort of person. These are all the signs and symptoms of undiagnosed sleep apnea. Now, if I'm being honest, most people don't want to go get their apnea tested because, number one, they don't want to go get a sleep test. And number two, they don't want to sleep with a CPAP machine on their face all night long.
All true.
Right? So let's talk about a few of the innovations that have occurred since COVID that have made this process significantally better.
So before you go into the innovations, sure. I just want to make sure that people also hear that sleep apnea is the treating sleep apnea is super important for many reasons besides sleep, nocturia, but also your high blood pressure. Blood pressure goes up if you have more sleep apnea. You're at higher risk for atrial fibrillation. And so we want your sleep apnea treated, and it's harder to lose weight when you have sleep apnea. So these are sort of things I want people to hear too, that even though they may not want to get it treated, it is important to get it treated. The other thing you said that I really liked was have people stop eating 3 hours before as well as drinking, because there's so many benefits to that as well. And I do want people to hear that again, because really don't want people eating that late anyway for reflux, but also for weight, right? Our metabolism, eating too much, eating as a society, we're eating way too much food, and really cutting that food off and even doing sort of a time restricted eating is also beneficial. So tell us about those methods or techniques that you were suggesting.
Absolutely. So first of all, I want to thank you for doubling down and double tapping on that, because I'm so used to talking about sleep apnea all the time. I forget that people don't know some of the unbelievably serious consequences of this thing, because what they think is like, well, I've had it for a long time. Who cares? I'm still alive. I guess I'm going to be fine. And we really do see the progression into hypertension. Then we see the regression into hypertension that cannot be treated by medication, which becomes even more problematic. Then you end up in the land of atrial fibrillation usually. And then you've got a real problem on your hands, right? So we don't want people going down this path. This is not a healthy path for them to be. Weight loss, I think, was another great point to make to a lot of people out there. To be clear, if you have any weight loss goals, period, if you want to lose a single pound,
you got
undiagnosed sleep apnea, it isn't going to happen, right? So people need, the data is super strong on that. So people, there are other reasons to treat your sleep apnea than not to get atrial fibrillation. Okay, let's talk about the methodology, because I think there's some really cool things that have been going on there that people might enjoy learning about. So first of all, it used to be that you had to go into this weird place. It looked like a hotel inside the hospital. There was a bed there. It was kind of gross. It wasn't
still like that in some places.
I know it is still like that in some places. And it's very clinical. It doesn't feel very homey. It doesn't feel like an environment in which you would want to sleep. Not only that, when you show up at about 8 o'clock at night, there's a technologist there who's going to make markings all over your head, going to glue 27 electrodes to your body, put respiratory belts across your chest, stick you in a bed with a video camera on you, walk into the next room and say, hey, by the way, go to sleep. Okay. So we know this is not the best in terms of assessment tools. Ever since COVID happened and nobody wants to sleep in the same bed or have electrodes used on them because they were all reusable electrodes, everything has actually now moved almost exclusively to home sleep testing. Now, I want to be clear for people who are not eligible for home sleep testing. Let's say they have dexterity issues. Let's say they have neurologic issues. Let's say there's a whole host of reasons why you may still need a in-lab study. But I would argue for probably 75 to 85% of the US population, and probably worldwide, you can do a home sleep test and we can diagnose you with sleep apnea pretty easily.
Interesting. That's interesting. I thought the accuracy was an issue. So a lot of the sleep specialists are pushing people, if they have a negative test, it certainly at a home, they'll repeat it in-house.
So we did that because of the accuracy issues of the old devices. Post-COVID, we don't really have to do that anymore because the devices have gotten so much more accurate. And they're all FDA approved. They are full-on medical devices. And so I would argue that we've fortunately innovated ourselves past a lot of that stuff. Now, don't get me wrong. On occasion, we'll send up somebody home for a home sleep study and we just don't get good data, or for whatever reason, their body doesn't seem to conduct the data well. Maybe there's a plate in their hip or, whatever. Like there's a whole host of reasons why some of these things won't work. As an example, this is kind of a funny story. We had a person, we had a wrist worn device where we were collecting data off of the wrist, as well as the pulse ox from the finger. And the individual had a tattoo that went all the way up their hand. And we discovered that we couldn't collect as accurate a data because the tattoo
but just the pulse ox, just from the pulse ox, right? Yeah,
exactly. Right. So we were like, okay, we got to send this one to the lab, that kind of stuff. But generally speaking, we can definitely get people. And here's the best part is it's in your own bed, right? So you're comfortable. You're not in this weird environment. So we really do get, I would argue, better data when we do this at home. Right. So that's number one, is if you're worried about a sleep test and the weirdness of it all, stop. It's all been pretty much solved, and we can do a lot of this at home. The second reason that most people don't want to get a sleep test done is because they don't want the treatment modality called CPAP, which stands for continuous positive airway pressure. So CPAP turns out to be a very interesting device, but if I'm going to give you the basic biomechanics of it, you're sleeping with the hair dryer blowing up your nose all night long. That's the bottom line. Okay. So what happens is sleep apnea is basically where your throat collapses onto itself due to some level of physical obstruction, big tonsils, extra adipose tissue, a fat tongue, what have you. Right. And so when you stick this mask on your nose, it shoots a thin stream of just air. And when it hits the blocked area, it just ever so slightly opens it up, shoots air to your lungs, and everything's great. Here's the problem. It works 99% of the time. It is actually the single treatment modality that works better than any other in all of medicine. However, you got to sleep with a mask on your face, blowing air up your nose all night long.
So what other options are there?
Yeah. Say again.
So what options are there for people?
So I'm so glad you asked, because there are a lot of options. So fairly recently, I'd say within the last 10 years, they started to create dental devices. And so there's a dental device that's an upper and a lower, and it pulls the lower jaw forward by a few millimeters, which opens up the posterior airway space, which is where usually the collapse has a tendency to occur. And they work really, really well, even for super severe cases. So I have a tendency to lean more towards some of those dental appliances at times. I want to be very clear. The dental appliances have a tendency to work in the mild to moderate cases. When you've got moderate leaning on severe and severe cases, it's not so easy. I mean, you really have to push jaws forward. And when you do that, you can end up with TMJ, or you can end up with tooth movement, and that becomes problematic as well. So for folks out there, if you think you have undiagnosed sleep apnea, number one, go get tested. But number two, talk to your dentist, because that's who we would actually want to develop the device itself. And there's actually, believe it or not, a board of dental sleep medicine where dentists can go and get credentialed to be able to create these devices.
Okay, so that has to be from a dentist. So you have to go see your dentist in order to get that device.
Absolutely. There are also surgeries. Now, I'm going to be honest with you. I'm not a surgeon, and I'm not a big fan of surgery because once it's out, it's not coming back. And to be fair, surgeries work maybe 50% of the time, maybe. And by the way, for the most painful surgery, which is called a UPPP, the 50% of the time, the tissue grows back anyway. Yeah, so you end up with a real mess of a situation. Now, there's something new that came on the market about 24 months ago that I think is quite spectacular. And it is called Excite OSA. To be clear, I have no affiliation with them. I just think this thing is really cool.
This is the ear, nose, and throat doctors put this in, right?
Well, no. You're thinking of Inspire.
Oh, yes, you're right.
I'm going to talk about Inspire next. I'm talking about this thing called Excite OSA. It's actually a tongue device, and it's actually like a TENS unit for the tongue. And so what they do is they put a small electrical pad on either side of the tongue. Like a TENS unit, it'll shoot an electrical signal back and forth. What it ends up doing over the course of time is helping the tongue kind of, for lack of a better word, ooze some of the gross stuff that's stuck inside of it. And it actually shrinks the tongue itself by approximately 1 millimeter to 1.5 millimeters. Whoa. That becomes important because it pulls the tongue away from the back of the throat by 1 millimeter or 2, which is just enough for us to be able to probably get people past their sleep apnea. So this is the newest, latest, greatest device. It replaces CPAP. You wear it during the daytime for about 30 minutes for about 6 weeks. And then eventually you get off CPAP altogether, which is kind of miraculous. The surgery that you were talking about is called Inspire. This is, I think, probably out of all the surgeries, it's probably the best one. A good friend of mine is an ENT surgeon here in California, and he does somewhere between 8 and 10 of these a week. So he's probably the number one person out here who does them. There's a small, like 50-cent piece that's the battery that's tucked underneath the clavicle, and then they snake wires up inside your, like, outside your neck, but under your skin, and one hits the vagus nerve and one hits the back of your tongue. And then every time your tongue falls backwards, it shocks it and moves it forward. So the Excite OSA kind of does that to it during the day, right? Whereas the Inspire is something that you have to just wear. And again, it's implanted in you. The only big drawback for Inspire that I see, other than the initial surgical intervention, is every 10 years you have to change the battery.
And just to clarify for the community, there's no pain with the stimulation, right?
Oh, so yes, of course. Yeah, it's not like your tongue is zipping out of your mouth and you're like, bah! Like, no, none of that is happening.
Yes, very helpful. Thank you, Michael. That's amazing. So I want to step back a little bit, and I want to talk about, so this was super helpful. I haven't forgotten about the dolphin, which I want to hear about too, but I want to switch topics just so that to make sure we have enough time for everything. And I want to talk about what is optimal sleep and why should we care as a cardiologist, why should I care about the amount of sleep that my patients sleep? Because I do care about it. And so from your perspective, why should we care about sleep? What's the optimal sleep? And then, I have this darn watch that now, that my husband bought me that drives me crazy. I have to tell you.
I'm sure.
But the one piece that I've become kind of fascinated by is these stages. And I want to kind of go through these stages of sleep. So before we get into that, I'll let you answer, like, what's the optimal sleep? Should we think about it by age, like the American Sleep Association or Foundation suggests? And why should we care?
Great questions. So what is optimal sleep? So number one, it is different for every single human on earth. I want everybody out there to understand something. Sleep is flexible. Okay. So number one, nobody gets optimal sleep every single night. Not even me, the sleep doctor. Okay. So that is not a goal that anybody out there should be trying to reach, okay? Especially, by the way, if you buy one of these tracking devices like an Oura Ring or a Whoop strap or an Apple Watch or a Garmin or any of these things, these are rudimentary devices. These are not medical devices. And so they're not, number one, giving you great information. So we'll talk about trackers in just a second, but let's talk about optimization in total. What we're really looking for is for people to wake up and feel good. That is kind of the end all be all of it all. And what we've discovered is that seems to happen when you get 7 hours of uninterrupted sleep, and the sleep is of reasonable quality. So historically, most doctors have always said, you need to get this amount of time of sleep versus, hey, we'd like you to get this amount of time, but quite frankly, we're actually more interested in the quality of it. And let's take a look at that. Now, for the audience members, how do we measure quality of sleep is probably a big question. We look at it in 2 different ways. Number one is by a metric called sleep efficiency, which is how much time do you spend in bed asleep, right? It should be about 85% or higher. And then number 2 is we look at it based on stages, which is where I think you want to go, which is what are these stages? How much of each stage should we have? And what do the stages do? Like, do we really need them? Like, why do we have them in there? That kind of stuff. So,
well, I started on this process to reading about it because I'm a compulsive science reader. And I feel like it's less clear to me now than there's a lot out there that does no consistency.
So let me make it more consistent for you. So first of all, stage 1 sleep is merely a transition from wake into sleep. It's kind of just opening the door. We don't really look to have a lot of stage 1, usually less than 2 to 3% across the night. And the statistics I'm going to give you are not based on age. These are general statistics for men and women, I would say in their probably 20s to 40s. As you get older, things change. As you're younger, things change. So I'm just talking about kind of that sliver of people in there. Stage 2 is the preponderance of the night. Roughly 50%, 50% of the night is going to be spent in stage 2. And in some cases, more, depending upon if you have alcohol too close to bedtime, if you have caffeine too close to bedtime, if you have an emotional argument too close to bedtime. All of these different things can have varying effects on the amounts of the different stages of sleep. To be fair, while stage 2 does some interesting things from a memory standpoint, you have these things called spindles and these things called K complexes, which we believe have something to do with memorial content. If I'm being honest, I don't really educate people that deep into the stage 2 of it all. I let them know it's pretty much a buffer that helps you get from one stage to the next. Stage 3 and 4 is really where the money kind of meets the road, if you will. And stage 3 and 4, which by the way, we now call stage 3, 4, or just stage 3, we've combined them. This is the physical restoration. This is the wake up and feel great sleep. And this is where a few major things have a tendency to go on. Number one, the largest bolus of growth hormone is emitted during stage 3, 4 sleep. So this is when true cellular repair appears to occur. So when you pull a muscle or you strain a this or you break a that, stage 3, 4 sleep is exactly where you want to be, because that's where it kind of bringing the car into the body shop and getting the dents and the dinks and the scratches sort of pulled out. Now,
and a lot of places call this deep sleep, correct?
Yes. So it is synonymous. So stage 3 sleep, stage 3, 4 sleep, and deep sleep are all the same stuff. So you can just use those interchangeably. Now, there's a second process that goes on during stage 3, 4 sleep called the glymphatic system that turns out to be very, very important. So the glymphatic system, I call this the waste management system of the brain. So it's like the garbage truck comes in and it scoops out these very particular proteins that have a tendency to accumulate in your brain and lower your neuroplasticity. These two proteins are beta amyloid and tau, and we don't want more of them. Okay, our body produces them and we want to get them out. And stage 3, 4 sleep is how we get this stuff out of our brains. Now, as a caveat, you've heard me mention alcohol a few times. Alcohol destroys stage 3, 4 sleep. So if you're somebody who likes to have a drink every single night before they go to bed, I'm letting you know that is not helping your sleep quality at all. It may make you feel sleepy. I'm not going to say that it doesn't, because alcohol does make people feel a little woozy and a little sleepy. But I will let you know, the closer you drink alcohol to lights out, the more damage it does to not only the glymphatic system, but also the growth hormone system that's emitted during that period of time as well.
In the short term or in the long term?
Both.
Okay. So just important for people to hear that about the alcohol is that piece. Okay. And can you explain and define neuroplasticity for people?
Sure. So I am not, so to be clear, I am not a neurologist and I'm not a neuroscientist. So I'm going to give you a sleep doctor's version of what I think neuroplasticity is. But basically what neuroplasticity is the brain's ability to adapt to new scenarios as they present themselves, right? And so if you present alcohol into the brain, right, then that will slow down the brain's ability to move around, transport information, transport different actions and things of that nature. And so neuroplasticity gets slowed down when we put things in our bodies, for example, that are depressants, like alcohol would be, right?
Yeah.
We're good?
Yeah.
So REM sleep, I just want to do a little bit on REM.
That's what I was, no, that's what I was hoping you were going to talk about.
Oh yeah. So REM sleep is one of my favorites. And there's a lot of reasons why, but what's interesting about REM is we've really discovered that REM is the scenario where you basically move information from your short-term memory to your long-term memory, right? So your brain creates kind of this organizational substructure, kind of like a filing cabinet, right? So you get data coming in through your eyes, through your ears, through your nose, and through your mouth, and you want to keep that data. REM sleep is where that data kind of gets shuffled around and some of it gets thrown away, the stuff that's not necessary, and then some of it goes into deep memory, locked and loaded into your hard drive, okay? So that's one of the things that happens during REM sleep. There's a couple others that are pretty interesting as well. There are these things called dreams. Okay. Now, these are these wild hallucinations that you have in your mind's eye with your eyes closed, and all kinds of crazy shit goes on in your dreams, right? And so a lot of people want to know, is there meaning in my dreams? What is that? Is that my unconscious trying to give me a message? All of these very interesting questions to be asked. So the answer is yes to all of it. However, there's a lot of stuff we don't know about dreams, and I'm kind of more on the hard science side than the soft science side. So here's what I can tell you about dreams in particular. Is dreams have a tendency to occur in REM sleep. However, you can dream in any stage of sleep. We know this because when we wake people up during naps during the daytime, when we know that they're not in REM sleep, and we ask them, what were you dreaming about? They report these fantastical dreams. So you can dream in almost any stage of sleep, but 80% of the time, if I wake you up in REM, you will report a dream to me. So that's number one. Number two is you dream in chapters of a book. So if I wake you up in the beginning of the night and I say, what's the theme of your dream? And you say, I'm in a race car. If I wake you up 4 hours later, you're probably still in the race car, or you are, something about that race car has led you into a new path, but the race car is kind of still around. Again, chapters in a book is kind of the way I would want people to think about it. Now, people oftentimes say, well, do dreams have a function, Michael? And I would argue that dreams are emotional metabolism. Let me explain. So one of the things that we know is during the dreaming process, any emotions that you had during the daytime, like you got into a fight with your spouse, or you got a great grade on your exam, or you made a bunch of money, all of those are emotions that your body has to deal with and process on some level. REM sleep appears to be the time, at least during your unconscious state, when you have a tendency to do the most of that. Now, we have this idea set, and it comes from the idea of what happens during nightmares. So a nightmare is a dream that becomes so scary that you can't process it any longer, so you wake up. And it stops the processing. And then when you go back to sleep, you end up having to go back to the beginning of the dream and come through it. And then you get to that same place and you wake up again. So we know when the emotion gets too high and too exacerbated during dreaming, you can wake up from it. And that is classically when we call it a nightmare versus a scary dream where you sleep all night long, but it doesn't cause you to wake up from it. So that's kind of function number two of REM sleep, right? We've got this emotional metabolism. So we've got a memorial content and we've got emotional metabolism as two major factors in REM sleep. When you think about REM sleep, there's also an interesting aspect to it that can be detrimental. So many people don't realize it, but during REM sleep, your body is completely paralyzed. You go completely what's called atonic. And the reason for this is that you don't act out your dreams. So I had a patient who had something called REM behavior disorder, where he actually acted out his dreams. Now,
Wow.
This patient was fascinating. So I'm from a small area outside Atlanta, Georgia, called Sandy Springs, Georgia. And it's a small there's a hunting community there. This fellow was a hunter. And so if you're a hunter and you shoot a deer and you don't kill it, you need to either slit its throat or crack its neck. It's the most humane thing to do. He woke up with his wife's head ready to crack her neck.
Oh my gosh.
Right? She was screaming her head off when he woke up, right? So the first question people usually ask me, did he kill her? Good news, no lives have been spared for me to tell you this story today.
Oh my goodness.
The second question people ask, are they still married? She is a patient woman, okay? And here's what we discovered is we utilized a treatment modality. We used a pharmaceutical treatment called Klonopin. We use 0.5 milligram, and it usually silences this type of behavior. So when we have sleepwalking, sleep talking, REM behavior disorder, people acting out during the evening, a very small dose of Klonopin can be very effective for them. Number one, I'm not a huge fan of Klonopin. It's an old drug, it's an addictive drug, and it's got street value and there's problems with it. So it's not necessarily the best thing in the world to do. But the more important aspect of the story is 35% of people with REM behavior disorder develop Parkinson's syndrome. 35%.
Wow.
Right. It's a big number. Sleep is a window into your health. Bottom line, mic drop, okay? If your sleep is weird, if your sleep is not doing what it should be, if it's not of higher quality, if it is not of the right length, if you're acting out, if you're gasping, if you're choking, trust me, your body is trying to tell you something here, okay? Like, this is the big blaring red flag to say, hey, something is going on. We really need to look into this. So I want to be very, very clear that while I joke around and I have a lot of fun and I love to, discuss sleep, sleep's a pretty serious topic. And it's something that we should all really take a look at. And when we're not sleeping well, I would argue that probably 75% of the time, that's a sign that some other system is not working correctly. And that can become even more problematic over time.
Fantastic. That's fantastic. I mean, there's so much to digest there. So thank you for that. It was awesome. But, so if I look at my Apple Watch, I'm a great sleeper. I love to sleep. Yeah. I like to nap. I sleep at least 7. If I can, I'll sleep 8. But when I look at my hours of sleep, and I am no longer in my 20s or 30s.
Come on. I thought you were.
I know, right? So, I spend most of my time in stage 2.
As you should.
But the amount of core sleep or deep sleep and the amount of REM is actually, and I know these are imperfect devices, could be 45 minutes or 30 minutes or an hour.
To be clear, these are beyond imperfect devices.
Yeah.
They stink. Okay. I want to be very, very clear. So I was
on the
board.
Oura Ring. What do you think about that?
I was on the board of Oura.
Okay.
I was on their advisory board. I know exactly how that thing works. I would argue Oura is probably the best of the worst. So it's probably the most accurate, but the level of accuracy that it is still at is unacceptable in the staging. I want to be very, very clear. Oura, Fitbit, and I think it's Whoop did head-to-head studies looking at all these trackers against full nighttime polysomnography to see like how accurate are all of them. And none of them could do staging correctly. None of them.
But how accurate? Like what was the percentage of the variability?
70%. So it's really problematic because here's what happens is people come to me just like you and they say, Michael, I've only got 14 minutes of deep sleep. How do I improve my deep sleep? Right. And so my very first reaction is, what'd you get the night before? And what'd you get the night before that? Because if your device is being consistently inaccurate, we can work with that. So I don't really give a shit if you only got 14 minutes of deep sleep. But if you got 14 minutes one night, 407 the next, and 234 the next, I want to know what happened during the delta, right? I want to know about the variation from the norm. I don't want people to get stuck on that number. I can't count the number of people who said, Oura hijacked my day because I woke up and felt great and I looked at my score and I got a 47, right? That's not what we're supposed to be doing, right? So number one, don't look at your data every day. Look at it on a weekly basis and look for trends. Look for deviations. Because of the lack of accuracy, you're really not getting numbers that you can make sound decisions on unless you see a massive deflection from where the main numbers kind of used to be. So I want to be very, very clear. I'm going to give everybody in the last minute or two here, I'm going to give everybody a few tips as to how to improve things like REM sleep and deep sleep. But I want to be clear. You may or may not see this on a ring or a watch or things like that. When you wake up, how you feel is the most important metric there is. We are, I believe, our own best doctors. We know our bodies better than anybody else. And so when you wake up and within, let's say 30 to 60 seconds, you're awake and you feel pretty good, you probably slept pretty good, right? But if you wake up and you're dragging it and you don't want to get out of bed and you hit the snooze 3 or 4 times, I can assure you something's going on. Lack of quality sleep, lack of quantity sleep, potentially an undiagnosed sleep disorder. That's when we would kind of start to look at it. So to answer your question, what could we do to possibly increase deep sleep or increase REM sleep as we get older? Because that's probably good stuff that we need to know anyway. A couple of things to think through. So number one, coffee and alcohol. So as I said before, alcohol destroys stage 3, 4 sleep. The closer to bedtime that you drink, the worse your sleep is. So am I advocating for day drinking? Yes, I am. So if you're going to watch the Super Bowl at noon, it's probably not going to affect your sleep if you have a couple of beers. But if you're going to watch, the Golden State Warriors tonight or whenever, and you're drinking in the evening time, it is going to have an effect. So do me a favor, have 0 alcohol within 3 hours of bedtime, and you should be able to see an improvement in your overall deep sleep. Same holds true for caffeine, but caffeine, you've got to actually stop much earlier in the daytime. A lot of people don't know this. Caffeine has a half-life of between 6 and 8 hours. So at the very latest, you want to be stopping at 2 p.m. Again, you'll see this will be quite helpful. And then a third thing is exercise. The single best way to improve deep sleep is with daily cardio. You don't have to run a marathon. I'm talking 15 minutes, walk the dog, go around your block, whatever, 3 times a day. You will absolutely positively see an improvement in your sleep. And then my number one tip, people always ask, if I could just do one thing, Michael, what would it be? Wake up at the same time 7 days a week. Let me explain. When you're falling asleep, your core biology, your core body temperature tends to rise till about 10:30 at night. It hits a peak and then it drops. That drop is a signal to your brain to release melatonin. However, your core body temperature continues to drop, right? At some point in time, it's going to have to turn north, right? And be able to get you waking up. As that happens in the middle of the night, number one, lots of people have a tendency to wake up. So I'm guessing there's a lot of people in the audience who say, but Michael, what do I do if I wake up between 1 and 3 o'clock in the morning and I can't fall back to sleep? Good news, I have an entire video that describes exactly what to do on my YouTube channel. So if you're into YouTube, swing on over to thesleepdoctor.com and you can figure that one out. But as your core body temperature begins to rise the next day, then you start to wake up. When you wake up in the morning, sunlight hits your eyeball and sends a signal to your brain to turn off the melatonin faucet in your head. It also sets a timer approximately 14 hours later. It's called the melatonin phase response curve. Why is this important for all of us? Because the time that you wake up directly determines when your internal ambient, right, your melatonin turns on. So if you're consistent waking up at 6 o'clock every morning, melatonin begins at around 8 o'clock at night, gets up and in about 90 minutes, then you can start to feel sleepy. But if you're waking up at 6 during the week and on Saturday you sleep until 8, guess what? Saturday night, melatonin doesn't kick off until 10. And so you've caused what's called social jet lag, which means when you stay up late on Friday, sleep in on Saturday, stay up late on Saturday, sleep in on Sunday, Monday sucks. And that's why. So if you can, my number one tip is please wake up at the same time 7 days a week.
You're amazing, Michael. Thank you so much for spending this time with us. I thought maybe you could just end by telling us about your book and just giving everybody, we'll put the information on your book in the show notes.
Thank you. So I have a new book out. It's called Sleep, Drink, Breathe. Wellness is too effing complicated. And it is. And so I just think that the world has gotten so, like, I'm at the gym and people are like, do I get a green drink? Do I hit the sauna? Do I go on the like, people don't even know what to do. And so I said, what are the basics that everybody needs to do that will be additive, right? Get your sleep in order, hydration, and learn things like breath work. I have personally found breathwork to be so instrumental in helping me with my levels of anxiety, my patients' levels of anxiety, depression, energy. Breathwork turns out to be a game changer if you just learn a little bit about it. And so the book is called Sleep, Drink, Breathe. Wellness is too complicated. And it's available wherever books are sold. So feel free to go grab a copy. And we have a 3-week program in it that by the end of the 3 weeks, we have you hydrated, we have you breathing, and we probably have you sleeping.
You're amazing. Well, thank you so much. Appreciate your time. This is Dr. Michael Breus, the sleep doctor, and we will have so much information about him in the show notes. Pick up his book, watch his YouTube channel. What a pleasure. Thank you so much.
Thank you.